So many of them from different state EMTs also will be attending on this.
Some people are.
So they are already there, a lot of people will be joining. Shall we check? Just introduce.
సార్ కి హోస్టింగ్ అంటారా?
ఒక్క నిమిషం.
Raja, good afternoon to you.
Good afternoon, Dr.
Dr. Raja, good afternoon to you.
Good afternoon, one and all. We have here Dr. Nitasha Bagga. She is a neonatologist from Rainbow Hospital, and she will be talking about the neonatal emergencies. Before she starts the lecture, I request Director Dr. Ramana Rao to give an introductory note about the neonatal emergencies, about the services what we are providing in neonatology with our ambulance services, because many of our states have the neonatal ambulances which are running very well in those states. And our own state, Telangana, also wants to start some of the neonatal ambulances. So that is the reason we requested Dr. Nitasha to be here to deliver lecture on neonatal emergencies. Dr. Ramana, please give an introduction.
Good afternoon to all of you. Thank you. Yes, thank you, Dr. Raja Narsingravaru, and thank you everyone in this webinar on neonatal emergency management. We have a very distinguished speaker, Dr. Nitasha Bagga. She is a neonatologist at Rainbow, and she is a very efficient thorough. But what she got differentiated the doctors we have met in organization working on ensuring that newborns who require high-end care in tertiary care centers, NICUs, and you know that in India it is not only the access to the neonatal care, it is a quality neonatal care as well as affordability. So Dr. Nitasha Bagga is the first person whom I met who is able to provide the high-end clinical care, and she is able to ensure that the networking with various hospitals in the entire state of Andhra Pradesh through her innovative organization called Extra Mile, and through this Extra Mile she is ensuring that newborns who require prolonged stay in a tertiary care institutes like SNCUs and NICUs, she is able to financially support them. I am sure that India requires many clinical leaders who will understand the financial accessibility challenges for the high-risk newborns. So thank you so much, Dr. Nitasha, for accepting our invitation with a short notice. And for the benefit of all others who may not be familiar with our neonatology related, all our EMTs in all our ambulances are expected to take care of the essential newborn care as a point number one, and which is a part of the foundation training program. And we are also training our EMTs to identify the high-risk newborn, and then they will connect with the doctors for the online medical direction. The right hospital is identified ambulances where it is meant for the interfacility transfers from the SNCU to the NICUs and vice versa also. And you may be aware that in all the operating states, if you look into the government's articulation, the 108 system is established to reduce the maternal mortality rate and the infant mortality rate. This is the first sentence you have identified from every state government vis-a-vis the 108 system. under the infant mortality rate cited by Dr. Nitasha on those things. Without wasting much time on this, congratulate her for our founder of being the founder for Extra Mile Foundation and accepting our request. We look forward to a very enlightening Zoom call session. Over to you, Dr. Nitasha and Dr. Raja Narsinga.
Thank you, Dr. Ramana. So, I have introduced Dr. Nitasha to tell more about her. She has a lot of activities, what she does. One of the very nice thing what she did is in the last 1 year, she has started Extra Mile Foundation in the city, and that was founded by, and this was mainly to save premature and sick neonates who can survive with good NICU care, and where there is where they cannot afford. She was telling when we were meeting the director and all, that when they cannot pay the amount, so what they do is 1/3 of the amount will be paid by the donor, 1/3 by the hospital. So she transfers the hospital to the place where they can give a good concession, so that it will not be a good big burden for the patients. And this was inaugurated by one of the Bollywood actress, Mrs. Karishma Kapoor, and I was very fortunate to attend that ceremony, which had happened a year ago. Apart from this, Dr. Nitasha, she has a lot of publications. She has areas of interest are preterm nutrition and breastfeeding. And as I was told, she's the founder of what you call it as the Extra Mile Foundation. So with this short introduction, there are a lot of things which I should tell, but since of concern of the time, I cannot tell all those things. So with this short introduction, I request Dr. Nitasha Bagga to start her lecture. So to inform her, many of them are doctors, not only in this August hall. There are a lot of doctors who are attending on Zoom, because we are operating in many of the states, and different state level doctors are attending, apart from the paramedic who are attending. I'm assuming that many of the paramedics who are here are from Goa and Tamil Nadu. Yeah. The main reason why we invited them is we have a lot of neonatal ambulances in Tamil Nadu and Goa. Almost about 64 ambulances are there, and many of them may be placed, according to their performance, they may be placed in the neonatal ambulance. So that is the reason why we requested them to be a part of this particular lecture. Thank you, Dr. Nitasha, please.
Thank you so much, Raja sir, for giving me the opportunity to stand here and talk something about neonates, and I am really happy to see all of you, those who are so much dedicatedly involved in this work. Although at outside when we see 108 ambulances running, we don't feel that so much of hard work is done behind that. So frankly speaking, when I visited this place over last 1 hour, I was really surprised that this much of hard work has been happening behind 108, and it's all 3 cheers to all the workers, those who are spending day and night to save those lives. So that's very encouraging for me. So I'll start with, so I have prepared a talk on neonatal emergencies. I'm not very sure whether I'll be able to do justice to all of you, but I have tried to simplify it by putting some pictures, and so that I can cater all the doctors as well as the paramedic staff. And in case if any issues, any questions are there, please feel free to interrupt and talk, or we can talk at the end of the session. So to begin with, this is my place of work where I have been working for the last 17 years in Hyderabad at Rainbow Children's Hospital. I am working as a pediatrician and neonatologist there. This is my team with whom I work, and without team, intensive care is not possible. And this is my newborn intensive care unit where I work. So I have touch based around 5 or 6 important topics which come as a part of neonatal emergencies. Although talking a lot on neonatal resuscitation is out of scope for this particular day, but I have touched base few things which are latest 2020 guidelines from American Heart Association, which we really follow for the newborn emergencies for the NRP. So when we say this approximately, if you say only 10% of the newborns need resuscitation, 90% of the newborns do not need any resuscitation, and less than 1% require extensive resuscitation measures like cardiac compressions and medications. So those 10% of the babies is what we have to say. So that is the onus onto the neonatologist or the paramedical staff who is going to be skill-based trainers into this. So when we talk about neonatal resuscitation, ventilation is very important for any neonatal resuscitation. And ABCs, you all know about any adult resuscitation also. The extra point which is added is temperature. When we talk about a full-term baby or a preterm baby, we talk about PABCD. So that is temperature care. Thermal care is very, very important for a newborn baby. That is a premature baby or a full-term mature baby. And airway, breathing, circulation, it's the same thing as you do in the adult resuscitation or pediatric resuscitation. And the drugs and medications are important here. So I would not be discussing the whole resuscitation, but this has been updated in 2020, and 2020 is the model which we are following right now for the neonatal resuscitation programs and policies. So neonatal resuscitation is something like a teamwork and with lot of cognition and as well as technically you all should be updated about it, what to do next. So that as well as this resuscitation program, we do a lot of NRT sessions which is called as NALS, and for even the paramedics, and maybe probably sometime in this year we can plan one here as well where we can do a lot of training for the neonatal resuscitation. So I would just very briefly explain the algorithm, which is the latest one. So when we go and attend any newborn delivery, or it might happen in an ambulance, or you might need to land up into some emergency, a very important thing is to understand antenatally, because a lot of things when the newborn baby is born depends upon what was the 9 months when the baby was inside mother's womb. So antenatally, whether she had any hypertension, whether she had any cardiac diseases, whether she had any concerns during, so antenatal part before being born is very, very important for us, and we should be able to know about it. And after birth, the 3 questions, whether it is a term gestation or not, or a preterm baby, whether the tone is good, whether the baby is breathing or crying. So these are the 3 important questions which all of you should remember. And if the answer to this is yes, it's a term gestation, baby cried immediately after birth with a good tone, the baby goes to the mother's side, and we just do the basic cleaning and hand it over the baby to the mother. But if either of the questions is no, the answer is no, we have to make sure that we provide warmth, dry the baby, stimulate the baby, position the airway, and suction if at all it is required. These are the basic initial steps which all of you as a part of neonatal resuscitation program should know. That if at all baby is not crying, baby is not breathing, baby, if at all it's a premature baby, the warmth is very, very important, the warm care for the baby, and we should be able to dry the baby, stimulate, position the airways, and if at all there are any secretions, we should do the suction. And we should look in for the respiratory rate and the heart rate of the baby. If when we took respiratory rate and heart rate, if the respiratory rate baby is going into apnea or is having any kind of gasping, or the heart rate is less than 100 per minute, nothing like that. If the baby is just having persistent cyanosis or labored breathing but there is no apnea and heart rate is fine, just give the routine care, not to worry. But in case, if there is a labored breathing and persistent cyanosis, we have to make sure that we position and clear the airway, do the saturation monitoring, and in case required supplementary oxygen, and put the baby on CPAP. After that, once all these things are done, you all must be doing in adults, you must be learning about how to do the team briefing. The same place, once we have done all those things and we are handing over the patient either to the mother bag or to any hospital care, then we should be able to say what are the post-resuscitation care we need to do over there. For example, going back there, if the baby's heart rate was less than 100, and or baby was having apnea or gasping breathing, then the role of positive pressure ventilation comes, saturation monitoring, and we also have to look in for the ECG monitoring for these babies, those who have heart rate of less than 100. So this completes 1 minute of your initial resuscitation after the initial steps. Now when the heart rate is less than 100 per minute, if it is not there, we just do the post-resuscitation care, but if the heart rate is less than 100 per minute, we should make sure whenever we are giving, we started with the positive pressure ventilation, we should be able to check the chest movements, like when we are doing the bagging for the baby, is the chest rise happening or not properly? What are the ventilation corrective measures? There might be pooling of secretions which are blocking the whole mouth of the baby, because of which we are not able to give the positive breaths, and there might be needing the intubation. So that is something which we have to look in for. And again, we should check the heart rate, whether the heart rate is less than 60 or not, or heart rate is more than 60. So you all must be knowing about this. This is one of the very frequent barcodes which is used in MR SOPA. So basically, it is to adjust the mask to make sure that the seal of the baby is good when we are giving a positive pressure ventilation. We should be able to reposition the airway in case if it is not happening properly. Suctioning, as I told you, open the mouth properly, use a good suction, and we might need to increase the pressure if we notice that the chest rise of the baby is not happening. Consider the airway alternative. We might need to put endotracheal intubation, or we might need to do a laryngeal mask airway. Either of these things has to be. So if somebody is going out for a skill resuscitation, or there is a neonatal emergency, if you are not able to resuscitate, always just close your eyes and remember, 2 minutes 65 to 70%, 3 minutes is 70 to 75. By the end of 10 minutes, we are able to have achieved 85 to 95% of the saturation is normal. Right? So this saturation, sometimes when we immediately afterwards, for example, you are all in an ambulance and the baby gets delivered, you have a saturation probe, but you might see, okay, saturation at just 60 to 65. This is normal saturation for a 1 minute old baby. Then by 2 minutes it increases by 5, another 3 minutes it increases by 5. So at the end of 10 minutes of the baby, if you are able to achieve 85 to 95% of saturation, is normal for you. So now when we say that the heart rate was less than 60, so that is the indication where we really need to intubate the baby, do the chest compression and coordinate with the positive pressure ventilation. If the heart rate is still less than 60 per minute, is the indication to start with the medications. I would not expect you to learn by heart at this stage, but maybe I will transfer some of this literature, what I am giving it, to give it to you, so that you can go through it and you can learn from there. So the important tips for the resuscitation is every birth should be attended by at least one person who can perform the initial steps of resuscitation. If you remember the first minute steps of resuscitation. So all the paramedical staff, leading the pediatricians and the newborn specialists, those who are skilled trained workers into this, those who are paramedical staff should have knowing at least the initial steps of resuscitation and should be comfortable in doing that. And in case of any assistance of significant perinatal risk factor, additional person with the resuscitation skills should be immediately available. So what does the perinatal risk factors mean? As I told you, there might be a mother who has hypertension, there might be a mother who is having diabetes, there might be a mother who is having some heart disease, because of which we might get a compromised baby. So we should all know what are the antenatal things going on with the mother, so that we can decide who should be accompanying for the resuscitation. Like you have got a call center. So in the call center, we might need to feed few things. If you get a call that there is an emergency delivery and the baby might be delivered, so we should have few questionnaires. Any antenatal concern with the mother, 9 months of pregnancy has gone well, how was the antenatal checkup? It might just take 30 seconds to know, because parents would be knowing that how many antenatal checkups were there and is there any concern, so that if required we can send a skilled person over there. So a standard checklist to ensure that all necessary supplies and equipment are to be present, functioning and may be helpful. And what we call is golden minute. The first 60 seconds after the delivery are allotted for completing the initial steps, re-evaluating and beginning of the ventilation. And although the 60-second mark is not precisely defined by science, it is important to avoid unnecessary delay in the initiation, because the first 1 minute of life, whenever baby is born, the first 1 minute of life, if it is decrease in the oxygen supply to the brain, that can cause a prolonged, lifelong damage of hypoxia to the brain. So it's very important that we do this newborn care in the first 1 minute. Once the positive pressure ventilation or supplementary oxygen administration is started, assessment should consist of simultaneous evaluation of 3 vital characteristics, that is the heart rate, respiration and the oxygen saturation. The most sensitive indicator of successful response to each step is heart rate. So whenever you are giving, I told in 3 steps, whenever you are giving positive pressure ventilation, we always have to check that the heart rate is getting better or not. So the normal heart rate for the newborn is somewhere between 120 to 160, which is little different from the adult heart rate or even for the pediatric heart rate. So we have to make sure that the baby is able to have a normal heart rate after the successful steps of resuscitation. This is something which I wanted to talk in an emergency, this is golden hour management of the premature baby, because I felt this is one of the emergency situations which any one of you might face wherever the premature delivery happens suddenly, either at home or in the ambulance, or you might need to pick up a baby. So the golden hour management of any preterm baby, or you might even need to attend the delivery in some of the small newborn care units in the districts wherever you are placed, is a very important time for the whole life. So this 1 hour is on one side and the whole life of the premature baby is on one side, because if you are not able to do a good care of this 1 hour, this child might be having so much of handicaps in the future life. So this first 60 minutes are very important for the premature baby. So what does the golden hour concept means? The golden hour in a premature baby concept includes practicing all the evidence-based interventions for the term or the preterm neonates in the initial 60 minutes of postnatal life for a better long-term outcome. So that is why it is called as the golden hour. Why it is important? Because studies have evaluated the concept of golden hour in preterm neonates showed marked reductions in hypothermia, in hypoglycemia, in intraventricular hemorrhage, in bronchopulmonary dysplasia, retinopathy of prematurity. So these are few. You might be conversant with few terms and might not be conversant with few terms, but these 5 are the commonest risk factor for the premature baby whenever a baby is born before 37 weeks of gestation, that is before term. So when we take care of the golden hour, that golden hour will take care of all these emergencies or the long-term complications for the baby. So what do we all take care? We take care of thermoregulation, that is temperature maintenance in the golden hour. We make sure that the functional residual capacity of the lungs, that is the normal breathing of the lungs, is maintained. We try to avoid hyperoxia, that means try to avoid more oxygen supply, and we try to be surfactant in this time, and early nutrition. So just to tell few technical terms for the paramedic staff, so hyperoxia for a premature baby is very dangerous to their eyes and the brain. So we have to make sure that we give, that is why we give titrated oxygen over here. The functional, we give FiO2, which is that should be started from 21% to 30% for the resuscitation, and we don't give the free flow oxygen for the resuscitation for the premature baby. It is something very different which you do in the pediatrics or in the adult population. For the premature baby, hyperoxia is as bad as hypoxia. So we have to be careful. Surfactant is a kind of small, it's a medicine, or you can say it's a chemical which is installed into the baby's lungs for the maturity of the lungs if the baby is born premature. So this surfactant is actually transferred from mother to the baby after 34 weeks. So if the baby is born before 34 weeks, we have to give it artificially. When we put the tube into baby's trachea, there we instill this surfactant so that the baby's lung can start breathing, because the lungs are completely collapsed when the baby is born premature. So the components of the golden hour are, first of all, the antenatal things, delivery room management, and immediate postnatal NICU care. So as I was talking to you, it's very important for any premature baby or for any mature baby also, for any obstetric emergencies if you are going, you should be able to make sure organizing a team and the parental counseling and expectations, you should be able to talk to them about it. These are two drugs which have actually revolutionized the neonatal field by saving the premature baby. So these are the 2 drugs which should be a part of your emergency kit at this stage. If at all you are going to have your neonatal emergencies, this is a part of any neonatal emergency kits, antineonatal steroids and magnesium sulfate, because these are the 2 drugs which can save this baby's future. These are not administered to the baby, these are administered to the mother. If, for example, after doing antenatal steroid, if I get 12 hours, my baby's outcome will be much better than not giving these steroids. So these should be a part of your obstetric emergency kit. Antenatal magnesium sulfate also, it prevents a lot of problems in future for the babies. So these 2 things should be a part of your emergency. When we do emergencies transports, we carry these steroids as well as magnesium sulfate with us. So now delivery in the healthcare facility which can provide appropriate neonatal care for the premature babies. So these are few quick delivery room practices which I have kept in. So you might be posted in some places where you might need to go in the delivery room also, or you might need to create an artificial delivery room at some point of time. So temperature maintenance, general handling, resuscitation support should be available, oxygen saturation targeting, vascular access support, and the safe transport to the NIC. So this is briefly, I have taken a picture of my delivery room setup where we create, if you can see over here. So if you can see over here in the first picture, so these are two dedicated areas. The first one is in the labor room and second one is in the OT complex. If you see, I'll show you from here.
Right.
Yeah. So this one, the first one is a place where you have a labor room complex, and this is the operation theatre. So these are two different operation theatre delivery station. It is one of, it is also there in your sim labs also, if you have seen the warmer with the small baby's place. So it should be very much adjacent where the baby can be brought within 20 to 30 seconds wherever mother is going to be delivered. So that is something is going to be helpful. We have got a radiant warmer and a neonatal resuscitation trolley is there. So if you see, the first one is a radiant warmer. This is a neonatal resuscitation trolley which contains all the equipments. There is a monitor over here and resuscitation trolley on the side, and this is the resuscitator, the T-piece resuscitator which we use to resuscitate the newborn babies. So important resuscitation equipments. This I am not very sure whether you all have been able to see, but this is something which is very important for any neonatal emergencies. Whosoever is going to attend the neonatal emergencies to the transport, not a very costly equipment, but a very life-saving, much better than the normal bag and mask ventilation which we do. So this is something T-piece resuscitator, and then we have got air oxygen suction port which should be there, and then we have got a suction apparatus which should be wall-mounted suction apparatus. In the other resuscitation equipments, we should have all the three size blades. So this is 00 blade and 00 and 0 blade, and then one size blade. So which is basically used for the extreme small babies like 24 to 26 weeks, those who are less than 750 grams. This one is used for those who are between 750 to 1.2 kilos and those who are more than 1.2 kgs. So these three, this laryngoscope set is important for us. Then we should have all the size EG tubes and the mask readily available, and an ambu bag. A documentation of resuscitation, there should be a proper documentation sheet which should be managed. Then this is the mega code which I was telling you. This is a new resuscitation page which has been launched by American Heart Association for 2020, and it should be there in all your ambulances so that you can easily look into it, see the timings and how long you should do the resuscitation should be there. The another important care, as I was telling you, temperature, thermoregulation for the preterm or for the term baby. So normally when we talk about normal temperature is 36.5 to 37.5 is the normal temperature for a newborn baby, or you can also say 97.5 Fahrenheit to 99.5 degree Fahrenheit. So admission temperature, if it is less than 36 degrees, it increases the mortality. Delivery room temperature should not be more than 25 to 26. And the polythene bags or the cling wraps are used for the delivery room. This is again another very important aspect when you are going to attend the delivery outside or any emergency deliveries. This is a simple cling wrap which you all must be using at your homes also, the foils, the cling wrap which you used to cover with the fruits or any of the things. A simple cling wrap which can save the loss of heat from the baby's body, because the surface area of the skin is so much that if the baby is just exposed to the air, we lose all the heat. So we just have to wrap the baby into the cling wrap. Apart from that, we can also have thermal mattresses which are very much available in the market. Once the baby is delivered, if you put it onto the thermal mattress, the baby can be taken care in terms of the temperature. They wrap the baby into simple cloth and you can keep the baby onto the thermal mattress. There should be a cap and a warm humidified air and oxygen should be used. The last thing which you can do is skin to skin contact with the mother. So in case if you don't have anything over there available, you can just put the baby onto the mother's chest or mother's abdomen, which will give warmth to the baby, and we can prevent heat loss from the body. So these are few pictures which I have shown for skin to skin contact. Immediately, these are all those emergency situations where you attend the delivery. As soon as the baby is delivered, put the baby to the mother's abdomen, which is, and take off the clothes so that there is direct skin to skin contact, and the baby will automatically crawl to the mother's breast for the breastfeeding. So these are something which is just basic. Wherever normal delivery happens, make sure you give a good skin to skin contact, and this will not only improve the temperature here but also maintains the good heart rate, good breathing efforts. Coming to the respiratory support, which is important, is during the transition period. So that means as soon as the baby is able to breathe, we really need to have a pulse oximeter put on the right wrist. As I told you about the first minute, second minute, up to 10 minutes of saturations, you should know what is normal and where should. If you should not start resuscitating a 1 minute old baby at 60 saturation, because 60 to 65 is normal at 1 minute. So what is normal, what is abnormal, you should be able to have that. Then, as I told you, delivery room CPAP is very, very important. Now, wherever it is possible in all your ambulances, this small kit is going to be a very, very useful thing where you can provide, wherever you are going to attend a delivery or any emergency, delivery room CPAP. Then we are supposed to avoid routine prophylactic intubations and blended oxygen. As I was telling you, no baby should be given 100% oxygen. The air and oxygen mixture of 30% resuscitation should be started, and it should be titrated to target minute specific saturations, which that means a first minute old baby 60 to 65 saturations is normal. So don't keep on doing positive pressure breaths to make saturation 100. It will not reach to 100 at first minute, but at the end of 10 minutes, you should be able to achieve more than 95% of the saturations. So this is the TP's resuscitation, which I would say that every 108 ambulance which is going to handle the neonatal emergencies should have. And apart from the inbuilt ventilator, because this is a mobile ventilator, it provides both positive pressure ventilation as well as PWD to the baby, and you can adjust the rates as well. So we have got an adjustable PIP, provides PWD, very easy and not a very costly instrument, but a life-saving instrument. So this is the TP's resuscitator. This is how the FiO2 is titrated over there. We can keep the FiO2 how much we want to keep, and rest of the mechanism is as similar to as you do the positive pressure ventilation with your bag. So this is something with which we provide the positive pressure breaths and put the mask onto the mouth. So this is how it is placed. So this is something which is very important. This is called as a TP's resuscitator. So this is the labor room or the OT or wherever, if at all you are planning to have one over here. The warmer here and the monitor, which should be multi-channel monitor, which should be able to have at least 4 things: it's your heart rate, blood pressures, respiratory rate, as well as respiratory rate. Yeah. So these 3 things should be there, and here you will have the temperature anyway. So this is a TP's resuscitator. A basic delivery room CPAP should be available. So this is the basic model of the labor room. Now coming to the safe transport, which I thought might be of interest for 108, and what are the various precautions for the safe transport of these babies. For example, you have attended a delivery or the baby delivered in the ambulance or somewhere on the roadside the baby has delivered. How best you can safely transport these babies. So these are few points which are very important. So a lot of time we miss talking to the parents, but here we are talking about the newborn baby, for which the parents would be definitely concerned. So briefing the parents about what all is the possibility with the baby, we should talk, and we should have availability of pre-warmed linen, for which we should be able to take care of the temperature, and transport incubator, a respiratory support in the form of TP's resuscitator, and a surfactant which I have told, and some saline and IV fluid should be available. So this is the mattress which I was talking to you. Again, not a very costly thing, but you can just wrap the baby inside this mattress and it will keep the baby warm for at least 2 hours. So that might even your transport will be safe for the travel for the baby. So this is, I just got my ambulance facility where we work as. So here we have got at least 2 dedicated ambulance facility available 24/7 at any point of time. And we have got, this is the transport incubator. If you see, like you have got a stretcher over there, on the same this thing we have got a transport incubator, which is a small for the small premature babies, and this is how it looks like. We keep the multi-channel monitor above it. It has got an inbuilt ventilator. So this is not only a transport incubator, it is a transport incubator and ventilator. So this is an inbuilt ventilator over here. This is the incubator and this is the multi-channel monitor. Here the pilot, the doctor sits, and the pilot of the ambulance will have a separate room, and here we have got a nursing staff. Sometimes we also allow parents to come along with us in the ambulance. So a dedicated neonatal transport incubator with a servo control incubator is something looks like this, which can fold and you can push it inside the this can be used for babies up to 4 kgs or 4.5 kgs also, starting from as small as 350 grams babies whom we have transported. So starting from as small baby who is just a hand-sized baby to a baby who is 4.5 to max of 5 kilo baby can be transported in this incubator. It is a servo control. That means we just have to put a probe onto the baby's abdomen and that will automatically control the temperature. You might receive the baby at 36 degrees for example, or 35 degrees. If you put this baby into the incubator, this is the place with which you adjust the temperature over here. These are the norms, and we reach the temperature of 36.5 to 38.5, which is normal. So this is servo control. Automatically the heat will be generated and will be circulated around the baby. So now this we have got the ventilator. This is the ventilator part of the incubator, which has got FiO2, PIP, PEEP, which which is connected with the air and the oxygen cylinder, which are inbuilt, which are just below the incubator. So this is something which I told you about the suction, which is again inbuilt. And these are the syringe pumps which we need to carry along because the sick babies might need so many inotropes, IV fluids. Because if we keep this baby even for 20-25 minutes without IV fluids, they go into hypoglycemia. And hypoglycemic injury is such an injury which is irreversible for the whole life. So infusion pumps carrying is very, very important. The rest of the structures are inbuilt with this. Another inbuilt thing, as sir was also showing in their ambulance, so in this also just under the incubator, we have a place where we keep extra oxygen cylinders so that on the way it might get, and these are the inbuilt air and oxygen cylinders. Multi-channel monitor, and also this is called as iStat. iStat is a mobile ABG machine which we carry because for us the cord blood gas is very important. Again, this is a very, very important instrument which a technician can use or a paramedic staff only uses, and they can just talk to the doctor saying how is the acidosis in the baby, how is the base excess of the baby, so do I need to give more fluids, do I need to start bicap for the baby, because by the time you reach to the healthcare facility, if it is half an hour also and the baby's base excess is 16 or 17, baby might have a cardiac arrest on the way. So this also tells not only base excess, not only about the carbon dioxide, the PO2s or PCOs, it also tells us a basic salt levels, sodium, potassium and chloride. So these are the three this thing which can be sudden killers for a premature or for a full-term baby also. So this gives us a basic idea about the lactate, basic idea about the salt levels, and basic idea about the acid and carbon dioxide and the oxygenation of the baby's blood. Then thermoregulation during the transport. One is just simple covering the baby. This is a small nest which we prepare for the premature babies with the pre-born unit. And other is the thermocare, the mattress which is available. Either you can buy that mattress and roll the mattress around the baby, or you can have this kind of nest which, because now when you move the ambulance fast, this baby will move significantly because it's a small baby, maybe a 1 kilo or 1.5 kilo, and there is a huge risk of having bleeding in the brain. So it really needs to be skilled so that it is so snugly fit into it that the baby doesn't move. So that is why not only the thermal care, we have to prepare this nesting so that we can drive the baby faster but at the same time safer. So this is very important. Transport kit, dedicated transport kit, like you all have already pre-prepared transport kit. In the same way, neonatal resuscitation trolley should be also taken along with it in the transport kit, which has got all the equipments, the list which I gave you at the time of resuscitation. So this is something which we prepare at Rainbow and we carry it for all the emergency purposes wherever we go. And this is checklisted all the time. We have also done, recently we have started the air transports also for the newborn babies. So these air transports, we just carry the same incubator till the airport. We carry the same incubator, and that incubator can be taken inside the trolley, and they also have their own incubator sets which is fixed inside the airbus. So rest of the equipments are same, the pressures are adjusted. We just take from the ambulance till here, and then that baby. So we have transported the babies from far off, from international transports also, like Singapore and Nepal. We have done the transports recently through this air ambulances. So these are also well equipped air ambulances for the transports. So this can also be one of the thoughts for the 108, because this costs huge. This costs almost 2 to 3 lakhs only for one single transport. So if at all something good can be done by the 108, also this is something which is doable, and it saves so many lives of the babies. Because now even Government of India has started the rail transport also. We have recently transported from Nagpur one of the babies, premature babies, with that incubator. They have inbuilt incubator in the trains now. So we transported a sick baby that was around 12 hours journey. So from the train, from Nagpur, the train came here, and they uplifted the baby at the station. So there is also a lot of scope in saving these babies across the states also, either through the air transport or through the rail transport or through the road transport, whatever it is. The kits are same, the expertise will be the same, the staff who can do the rail transport can do the ambulance transport, can do the air transport, only the equipments will be different. So new progress is what is the high frequency oscillator and the nitric oxide transport system, which we have recently launched 2 years back, and we have done around 20 plus transport across the state, because these are the babies who need high frequency oscillators. These are the babies, those can die any point of time. If they are not given this nitric oxide gas or high frequency oscillator, this is available only in very, very few cities in the whole country and very, very few hospitals. And we have saved out of those 2016 babies, and they have gone home, and they were almost going to die with the 60% saturations. So once we started high frequency nitric oxide over the road itself for 4 hours, that itself picked up the saturations to 80%, and by the time we brought them to the hospital, these babies were good enough actually and were almost touching 100%, because they suffer from so many hypoxic injuries to the lungs, which we call as PPHN. That's a pulmonary hypertension which a term baby or a preterm baby goes through. So this is another thing which should be reinvented. This is our the ventilator which was not being used. We reinvented and made this transport unit actually with the help of our biomedical engineers. So I think I will be lacking short of time. So I will just fastly tell about respiratory distress in the neonates. So whenever you have, sometimes you see a baby who is having a respiratory distress, there can be the cause because of the lungs, because of the cardiovascular causes. There can be a problem because of the metabolic disorder, metallurgical disorders. Sometimes it might be neurological as well. So this is all the list which might not be beneficial for the paramedical staff, but since I was told that there are a lot of doctors and anesthetists also in the group. So for a newborn baby, the cause is different for a term baby and for the preterm baby. So we should take a proper history from the parents. When did the respiratory distress start? How did it progress? How long is the problem? So these are few relevant histories which will help us. So for example, if there is a preterm baby who is having respiratory distress at birth, it might be just a simple respiratory distress syndrome. If there is a mother has got a prolonged rupture of membranes and there is a lot of leaking of water, or there is a UTI in the mother, there might be a problem of pneumonia in the baby because of which respiratory distress is there. If there is a motion, like meconium stain, the motion maybe has passed inside the mother's womb itself, there might be a meconium aspiration syndrome. If the mother has got a lot of fluid, that is called as polyhydramnios in the pregnancy, the cause of respiratory distress can be esophageal atresia, that will be absent of the esophagus. And if at all mother's fluid is lesser in the antenatal scans, it can be so many other things that the lungs have not built only, so pulmonary hypoplasia. And in the same way, there can be post-term baby liver cord prolapse or something like that, both asphyxia can be there, or if there is a consanguinity in the family, there might be inborn errors of metabolism. These are the common problems which we face, although I am sure we don't need to diagnose these problems in the emergencies, but if we have just a fair idea about all these problems, these are only 6-7 diseases in the neonatology. Neonatology is not beyond this actually. If as a basic trainers, if you have a basic idea of these few 7-8 diseases also, you will be able to identify even during the emergency period and give them the emergency management. So after that, examination is very important. I will skip off this slide because it might not be very useful for it, because we have to examine and see what all are the reasons for the respiratory distress, and we have to rule out the cardiac diseases. It's very important that we see the lower limb pulses and the femorals. If they are well felt, that means less likely to have a cardiac disorder. Pre and post ductal saturations are, so that means on the right hand side is what we call as pre-ductal. If you are able to measure the good saturation and the post-ductal saturations are almost normal, that means cardiac disorder is not there. So these are few hints which we can talk in one-to-one classes whenever we do a detailed classes for you all. So echocardiography is must. It might not be available, but wherever you transport, if at all you have a doubt that this might be a cardiac disease, you can refer to the hospital where echocardiography is available. Right? So I'll not go into the details of all those things. Few investigations which you can recommend once you drop the baby to the hospital is blood sugar, chest X-ray, hemoglobin, arterial blood gas, sepsis investigation, and a chest X-ray. So oxygen therapy is very important. That all the basic management which I have taught earlier will be the same management here. And think of the common conditions first. Relevant history and group physical examination is important. Cardiac cause is important for any child with the respiratory distress. There might be some surgical causes for the cause of respiratory distress, so X-ray is very important for the initial management. A quick brief onto the neonatal hypotension and shock. Again, it is very difficult to identify neonatal hypotension. We have to understand that the stages of shock, the first is a compensated shock. That means that the blood pressure will be normal, but there might be a problem and the vital organ functions will also be maintained. This is called as a compensated shock. Here you might have a problem with the heart rate. The heart rate might be high, but the blood pressure is normal. What is uncompensated shock is the next stage where the child or the baby goes into hypotension. There might be prolonged perfusion. What we say is the hands and the feet will start becoming cold, and the other organ functions will start getting deteriorating. If your baby is not caught in the uncompensated state, then after that we have got an irreversible stage of shock. So the shock signs are tachycardia, tachypnea, blood pressure will be normal in early stages. You should be able to see the capillary refill time. If the patient baby has got a bounding pulses or feeble pulses, the temperature difference in the body and the core temperature. If the baby has got a cold and mottled skin, if the altered sensorium or the urine output is, these are few early signs of shock, which as a basic assessor you all should know. So this can be a baby with a neonatal shock. So we should be able to identify early signs. If at all child has got a tachycardia, tachypnea and a compromising blood pressure, at least we can give the fluid bolus to that child initially for the initial resuscitation. So if we understand the signs of shock. Shock is not defined by the blood pressure. Always remember, hypotension is a very late sign of shock, especially in the neonates. I'm not very sure how do you distinguish in the adult shock, but for the neonatal shock, if hypotension is happening, means you are almost at a very late stage of medicine. So we should remember the early signs of hypotension. So these are various causes of hemodynamically unstable babies with the shock. So I will skip off this slide. So as I told, we should have a clinical background, looking into the heart rate, capillary refill time, pulses, urine output, heart rate and NIDP, that is non-invasive blood pressure. Few lab investigations which can help us identify shock is the blood gas, which I told we should carry high-stat. In that, electrolyte will also come. So fluid boluses we should be able to understand. We should carry in our ambulances few important inotropes which are important for the neonatal care, that will be adrenaline, dobutamine, dopamine and bilirubin. So key determinants is like we know about. I will not take much time in teaching the shock here, but yeah, this is something which is always make sure that the hemoglobin while you are managing shock is 10 grams at least, and always give the supplemental oxygen. The last scenario which I have taken is a neonatal seizure. So because you might get a newborn who might be on the road, got a seizure, or in the bus who got a seizure, or in the train might get seizures. So what would be your approach? You should be able to identify first of all, because all the babies might not have the classical manifestation of seizures. They might be just uprolling of eyeballs. There might be just losing the consciousness of the overall consciousness. There might be focal seizure, there might be only one hand which is moving like seizures. So that can also be seizure in the newborn babies. or there might be a overall generalized tonic-clonic seizures as you see in the adult. So these are the 4 different forms of seizures in the neonates. So we can have gaze eye movements, which is important. So there is something which is called jitteriness in the newborn, and there is so jitteriness is something, if at all baby is having seizures kind of activity, if you hold and it stops, that means it is not a seizure. Seizure will never stop when you are holding the baby. So we have to find out the difference between the jitteriness. So I will not go to the details of the causes of neonatal seizure, but I will tell you about the assessment. So once you should be able to take a brief history from the parents. Is there the first episode or has it happened earlier also? Basic examination, the neurological examination, and the basic investigations we should be able to perform whenever or wherever you are dropping the child for the first reference. So neonate with the seizure, you should be able to assess, basically secure the airway, as we have discussed in our NRP session, that you should be able to maintain the airway, breathing, circulation and temperature. You should be able to access the IV line as well as take the baseline sample investigations. You should be able to have the most common cause of seizures in the newborn is hypoglycemia. So you should have the sugar which is ready with you to supplement 2 ml per kilo, 10% dextrose. Second important cause is hypocalcemia in the newborn. So calcium levels being dropping. So you should also carry some calcium with you so that it can help the immediate quick remedy for the seizures. Apart from that, if the seizures persist, after giving glucose and calcium, you should be carrying some anti-seizure medications like you carry for the adult kit, phenobarbital, which can be given as IV or intravenous also, and repeat phenobarbital 10 mg per kg for those maximum twice. In case if it is not getting better, fenitoin. In case you can also use either levipil or lidocaine. Either of these drugs should be used as a second line of drugs. And last is midazolam infusion in case if the seizures persist. So again, this is refractory seizures. What are the various causes? I will not go into details of the refractory seizure because I would say it is beyond the scope of this class. But summing up, neonatal seizures, identification is important for you. Team effort, like how to manage any of the emergency care is important. And temperature, airway, breathing and circulation. And treat the treatable seizures like hypoglycemia, like hypocalcemia. If you carry the dextrose with you, it will help. Acute abdomen is something where you might have some abdominal symptoms which might get worsen immediately, like abdominal distension, peritonitis, there might be a mark, there might be a sudden bleeding in the newborn in the abdomen. So how you are going to manage all those emergencies? So again, antenatal history is important here. There might be a defect in the abdominal wall, there might be dilated loops in the babies. So there might be a fetal ascites because of which perforation is a possibility. So whenever you have got a baby with a bile stain vomiting, that is a green color vomiting, you should suspect intestinal obstruction. Whenever you might go and pick up a baby from somewhere in the emergency. There will be a constipation because of which abdominal distension can be there. There might be a blood in the stool, that can also itself be a major emergency. Systemic manifestations such as vascular instability, lethargy, shock, hypo and hypothermia. There might be a tense and tender and discolored abdomen might be there. Or there might be an inguinal hernia which are incarcerate. These are few sudden abdominal emergencies. This I have put a chart to identify whenever we have got a bilious aspirate. So this is really bad. That might be the initial beginning of the feeding indigestion in the newborn. So this color chart is also important for you to remember to understand what could be the cause of acute abdomen. So I will not go into the details. There might be a bloody stools for a well-looking child or a sick-looking child. So if it is a well-looking child and you see a newborn baby having the blood in the stools, it might be just the baby has swallowed the blood at the time of delivery. So that mother's blood which babies swallow at the time of delivery comes out. So that is one of the commonest thing for the bloody stool. So don't get panicked. We can take care of that. If there is a sick-looking baby, there might be a volvulus or intersection or NEC or enterocolitis. So just have to have a basic identification to understand which hospital facility you might have to transport the baby. So these are the few X-rays which I just put for this because you might get an X-ray over there which might be so many causes of intestinal obstructions. Management of acute deterioration, as any other, you have to take care of PABC. You should make sure that the NG aspirates are being done quite quickly. IV antibiotics should be considered, input-output monitoring. So this is basically about Extra Mile Foundation, which we have started a year back, just because some of the senior doctors wanted me to put it up. So I just put up 1 or 2 slides. Till now, we started in 19th of December. So this is basically a foundation which takes care of premature babies, those who are underprivileged and cannot be taken care in the high-end hospital or high-end treatment. So this gives treatment to all those underprivileged newborn babies, or not only treated any sick newborn, any surgical babies. So we are attached to different hospitals at Hyderabad as well as outside Hyderabad, also in Andhra Pradesh and Telangana. And till now we have helped this many babies, almost around near 100 babies in last 1 year, to go home with whatever best possible care we can give it to them. So these are the babies who have gone home with the help. Other is sharing the equitable care, as Dr. Raja Narsingh Rao was mentioning. We make sure that the hospital decrease the cost of the treatment so that these babies can go home. And around the third objective is basically we are involved into the healthcare workers training as well as the nursing training. So we basically pick up the girls, those who are posted in the various districts and need training. They come to us and get training, and then they go back and work there. So training, education and employment is something which works for these nurses. These are all district nurses. This is from Nalgonda. Some of the photographs are from Warangal and Vizag SNCs. So these are the nurses who come to me for various lactation counselings and breastfeeding workshops, and they get trained and they go back and work there in their respective. This one is from Warangal, where we have gone there and taken some workshops for the training of the nurses and the healthcare workers. So these are few programs which we started for the premature baby by giving them low flow oxygen meters just to cut off the oxygen supply. And spreading a word of awareness, we also have a few walks where we spread that premature babies can be safe, and all the healthcare workers like you all are also a part of this foundation whom we do the training. We are also attached to different schools where the children are attached with us for training programs. This is a group of volunteers who work for my association with their ideas, love, time, thoughts, resources. And these are the kiddo partners of Extra Mile. This is from the orphanage, one of the state-based orphanage who are being helped by the Extra Mile Foundation. So, few glimpses. These are the school children, those who are a part of Extra Mile. Around 250 school children who participate in our annual event of running and raise the funds for these underprivileged newborn babies. So this is my family. This is Extra Mile Foundation. I say giving back to the society, it's our duty and not a charity. And it is all of us moral responsibility. Not all of us can do great things, but we all can do small things with great love, which all of you are doing and spending your time over here. So this is a small video, just a minute's video. I hope you all enjoy this video for the babies who have been saved through Extra Mile.
पत्तों की गोद में आसमान से कूदे अंगड़ाई ले फिर करवट बदल कर नाजुक से मोती हंसती फिसल कर खो न जाइए तारे ज़मीं पर ये तो है सर्दी में धूप की किरणें उतरे जो आंगन को सुनहरा सा करने मन के अंधेरों को रोशन सा कर दे ठिठुरती हथेली की रंगत बदल खो न जाएंगे
Driving the sensor.
जैसे रंगोली पिचकारी, जैसे तितलियां फूलों की क्यारी, जैसे बिना मतलब का प्यारा रिश्ता हो कोई, ये तो आशा।
Thank you very much.
Thank you, doctor. It was really very, very interesting for all of us. I think everybody enjoyed her lecture. I have a lot of questions, but I leave it to the audience. First, you ask the questions, and if time permits, I'll ask. Any questions, Doctor?
Nice to meet you, ma'am. It's very great that this extra mile association is helping the poor children or poor newborns. Whenever we talk about NICU baby and the private setup is definitely good for NICU baby. When we look at government centers, they have limited facilities, limited doctors, nursing staff, and equipment. But it has been always a dream how everybody should get a proper care in private sector, and it's not about giving care, it's protecting about their brain or long-term healthy child should be given to society. And hearty congratulations, ma'am. It's a very great effort from your side, and probably if we can get a contact number, we can give it to those needy.
Yeah, sure, why not?
And talk was definitely excellent. Thanks a lot for revising all the important points.
Thank you.
And probably they need to know further basics which they learn in newborn. Thank you so much.
So, actually, all these things we put in our YouTubes, EMRI. So, what I have heard is some of the slides, because of the long distance, I don't know, they're not that clear. So, we requested that we take the slides from you and then.
Sure.
Some of my questions, Doctor, do you have any questions? About this, what you call iStat machine? You say that iStat machine has to be there in the ambulance.
We carry it.
You carry.
We carry it.
And
For any
you,
emergencies, we carry it with us.
okay. So who will be the nurse will be taking the blood and from the medical.
Yes.
Medical
A medical call or heel prick also we can do. If the baby is already
heel
in
prick.
heel
So if you do it heel prick, will you know about whether it's arterial or venous?
No, heel prick is just CBG, sir. Capillary. It's a
Capillary.
capillary gas.
So
Capillary blood gas is sufficient enough for a newborn baby to say us. So we don't need to have an arterial or venous gas specifically. Even the capillary blood gas is more than enough because there will be hardly around 20 to 30% different from the ABG.
okay.
So the oxygen levels will be 20-30% lesser than the ABG but more than the VBG,
okay.
the venous blood gas. So we do the
So
capillary
that
gas.
can be taken into
All the
consideration.
healthcare staff can be trained in it. It's the easiest method to do a blood gas, CBG. That's a capillary blood gas.
The other thing what I wanted.
Like GRBS you prick now,
Yeah,
the same way you have to take it in the capillary and do the gas over there. There
And
are
what is the
other
cost of
systems.
the machine?
Around 1.5 lakhs.
Okay. And the other thing is about this TPs. You said TPs is with the ventilator. What is the company?
So TPS, there are 2 or 3 companies. TPS is something which gives you positive PIP,
Yeah.
which gives you PWP. The rates is in your hands. You have to
Yeah,
control the rates, and it comes with a blender.
So can I keep a TPs without keeping a ventilator?
Yes, you do that. So
You-
many
you
times
don't
because
have-
every ambulance is not equipped with a ventilator.
So you carry TPs
Yes, we
with that.
carry TPs.
And the other thing is nowadays most of them they are not intubating at all.
Yeah.
With the high flow oxygen they are maintaining.
Yeah.
So
There's
this
no
device,
need-
and
there's no
again
need.
coming to the cost, what will be the cost of the TPs which you have shown?
This will be somewhere around 4.5.
Oh,
5.
it's
Or,
costly.
we have one more TPC suscitator which is coming up by this June, and that will be somewhere around 1.5 lakhs, which has been made by the doctors. So I'll give you the person's contact number which you can get it. That will be a good one.
Okay.
That
They
is
are-
inbuilt.
they are- they are all FD approved and all.
Yes.
Even this one which you are telling you.
FD.
That is very
FD.
good. So they're Indian make, right?
Yeah.
And it's very good you showed that all the monitors should be there. What is your opinion about what is the importance of ETCO2?
For the newborns, no sir, we don't use because the dead space will be so much. Now we don't use ETCO2 monitoring for a newborn baby. For premature, the anyways we cannot use. So we don't have any facility or we don't use ETCO2.
So even because again you have to invest 1.5 lakhs for the ETCO2 module to be implemented. So without ETCO2 also you say
we have never used it. I mean in this field, if I'm there for last 10 to 12 years, we have never used ETCO2 monitoring for a neonatal resuscitation.
Actually, we as anesthetists, if you ask me,
even our anesthetists also when they, but for pediatrics they use some. For neonatals we don't use. Neonatals we don't use. For pediatric we use. In our pediatric
EBG also can be corroborated because of speedy.
How about the nitric oxide? Is it so freely available?
It's very costly.
Very costly.
We have a nitric oxide cylinder, so we have around 4 cylinders.
Nitric oxide cylinder.
Nitric oxide. They're separate nitric oxide cylinders. Yeah. So nitric oxide cylinders, which we keep it ready for our ambulances, and inside the NICU also we use it because it is used only in our level 2 center, level 4 center in Banjara Hills. Don't use it anywhere else.
So from the audience and all the people who are there in the Zoom, anybody has any question? Dr. Ramana, if there are no questions, I request you to come on. You unmute yourself. Unmute yourself, Ramana.
Thank you so much. Am I audible now?
Now you are audible.
Yeah, thank you so much, Dr. Nitasha. You are a very inspirational speaker, and I'm sure the points you have touched are very, very useful for our own internal associates and the doctors and other healthcare providers who have participated in this program. And I'm sure that there will be take-home messages for each of us who have been spending the last 1 hour time. And more than that, we are all excited that a clinical leader like you have taken up certain causes and to improve the outcomes of the patient and reaching the unreached. So thank you once again, all the participants, for your active learning mode. And I see teams from other parts of the country, including Gujarat and Goa, teams of EMRI also. I want to thank the organizers, particularly our IT team who facilitated this thing to happen. And Dr. Nitasha should be a continued friend for EMRI, and I'm sure that down the line we'll get more opportunities to get her expertise in the area of neonatology. Thank you, everyone. Herewith I close the session closed. Thank you.
So, thank you, Dr. Nitasha. Thank you one and all who have attended. I think it was really interesting for me. I was also very much, because we do a lot of neonatal, we give a lot of neonatal anesthesia, but some of the points today I picked up from her presentation, which is very important to apply it for our regular practice. Once again, thank you, Dr. Nitasha. Thank you.
Thank you.
Lastly,
Recording stopped.
LNV in routine care,
Yeah.
the referees will be very
For the newborns.